So again, good morning, everyone. On behalf of Alive and Well Communities, we're very excited that you're joining us for this incredibly important and timely topic as we talk about suicide and when we see that ideation, how is it that we can respond and what resources are available to us? As we know, October 10th was World Mental Health Day as we work to really destigmatize mental health in our communities. In addition to that, Alive and Well Communities has a mission of activating communities to heal and recognizing that with mental health concerns, sometimes our community is suffering in silence. We also know that there's a national pandemic for youth and adolescents when it comes to mental health concerns, and know that there's a shortage of resources. So, this topic is incredibly important, and we're so eager to welcome two experts, one from Kansas City and one from St. Louis, to the space as we embark on this conversation. So first, I'd like to welcome Dr. Kristin Feeback. Dr. Kristin Feeback currently serves as the president and CEO of CommCare located in Kansas City. Dr. Feeback is a seasoned operational leader with over 20 years of accomplished experience in building influential relationships in both clinical and administrative capacities. She's developed an expertise in directing sound consultation to improve patient experiences, fiscal outcomes, and overall program efficiency. Dr. Feeback received her doctorate in psychology as well as MSW from Wichita State University, in addition to a BS in communication disorders from Fort Hays State University. Dr. Feeback is a licensed mental health professional that is deeply passionate about people getting their mental health needs proactively met with optimal solutions and care. Welcome, Dr. Feeback. We also have Amy Miller, and Amy Miller has over 25 years of professional experience in the business sector. As an eternal learner and in search of her full destiny, she was led to help people in the counseling field. She believes that she's truly doing what she wanted to be doing when she grew up. And Amy has a passion for working with teenagers, women, and families that have been impacted by trauma. Amy's philosophy is that there's good in everyone. Sometimes we just need a little help to bring the good to the surface. Amy is also certified to provide relationship trauma repair as well as trauma-informed services. So to our wonderful speakers today, I want to say thank you so much for joining us for this crucial topic. And welcome to our participants as we know that it takes all of us to build an alive and well community. Amy?
Good morning, everyone.
Good morning.
Good morning. So, as I am a licensed professional counselor here in the state of Missouri, and doing a lot of work within the community, working in private practice with A&A Inspirations, along with organized chaos on the nonprofit side. But I also do some work with an organization called Terrace House St. Louis, which is amazing. It's in the south side of St. Louis. And then I also am a therapist with BJC in the behavioral health, on the behavioral health side of things. So I'm pretty busy and moving around, but the core of everything that I do now professionally is being a clinician. And like it was mentioned in the bio, I love what I do, and I am who I wanted to be when I grew up. So as a grown-up, let's talk about suicide.
Hello.
Uh-oh. Is there a question? Okay, so we'll just keep on going here. So what I'm going to do is really kind of discuss like some skills, some things that we should be on the lookout for, and also kind of give some of the questions that we should be asking, some of the general things that we should be asking, whether it's in a professional setting or whether we're in a casual setting. Because one thing is for certain and two is for sure, we want to ensure that we take any suicidal ideation or remarks about harming ourselves or anything like that, we want to take it seriously. So we need to dig in and ask a little bit more, ask more questions to the person that we're talking to, not to be so pushy, but if it gets more serious, we might need to get a little pushy. Okay. I think questions are going to definitely come at the end, but if there are some things that are put in the chat, we can address those as we go. Leading cause of death among young people 10 to 24 years old, suicide. Okay. So when we began to talk about this, we talked about this epidemic that is forming with our young people. So I have a extreme passion toward addressing this issue and this concern amongst our young people, because we want to have our babies to have a chance, right? So what are some of the things that we can do? We want to listen. We want to listen to them. We want to observe, and that's whether they're young or whether or not they're old. We want to pay attention. We want to observe how they are communicating, social media, in person, via text message. We know a lot of especially our young kids, they're more tech savvy than anything. So I just found out something last night that there's a term or an acronym that's being used that's called KMS. And it's showing up on their social medias, and it means to kill myself. So I want to make sure that I say that again. That's KMS. We start seeing these in text messages on our social media. That is a sign that we need to start asking some questions. Okay. Understand that with people, the risks that they are experiencing that we may think are risks, for young people, they aren't even considered yet. So we have to take what they're saying extremely serious. And we want to make sure that we're responding with empathy and understanding. Guess what? If we don't understand, ask the question, ask for clarity, ask for understanding. Don't just assume, because people will tell you how they're feeling, what they are feeling. And this is a space where this is a very uncomfortable conversation to have, but we have to learn how to manage our feelings in the process of things coming to us or statements being said to us of maybe wanting to harm ourselves. Understanding this. Self-harm is different than a suicide attempt. So we want to make sure that we ask both. Okay. So self-harm could be a catalyst too, but if you have an individual that is around you that is self-harming, they may not think that is a suicide attempt, but yet it's something to ask questions about. Okay. Seek professional help if you are not a professional in these cases, and be very open and honest about your knowledge of it and where you are sitting. For our professionals, there are a few things that we are asking in the field. Plan. Number one is plan. Number two is means. Number three is intent. Plan. This is what I'm going to do. Means. This is how I'm going to do it. Intent. This is when I'm going to do it. There are three more that have been added, three more questions. After you get your plan, your means, and your intent, you're looking at frequency, duration, and intensity. Frequency, how often are you thinking about wanting to harm yourself? Duration, how long are these thoughts processing? Is it fleeting thoughts? Is it 1 hour or less, 1 to 4 hours, 4 to 8, 8+ hours, right? So we're working to get information. Intensity, how strong are these feelings that you are having that's going on for you? So plan, means, intent, frequency, duration, and intensity. those are just some of the skills, some of the questions that you can ask, some of the things that I do when I am talking to people, whether I am in doing clinician work or whether I am out and about in social settings, if these things come up. So that's the pieces that I have to present. If there are any questions, I can address them or we can move on.
I have a question. Wait a minute, I gotta get my screens up. I have a question. How do we get parents to take, let's just say, I think those are 6 really good points to help parents. But how do we get parents to take those seriously? I've worked in the past, my role was working with parents and in talking with them, how to get them to really not just brush it off and say, my child wouldn't do that, or my teen, they don't do that, when they are in their room for hours at a time and their child well, just to get them to think about those things. What's your approach?
My approach to that would be knowledge. So if we are in the education system, if we are, clinicians that are working in is information, 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 and we almost need to inundate them. Lots of times as adults and as parents, we want to think that they wouldn't hurt themselves or anything like that. But we have to be very realistic with them. We have to give them information, even if that means that if we're in the school, maybe the month of October, we are pushing information to parents, because all they need to hear is a couple of phrases. Maybe we are sending phrases out to them. If you hear your child saying this, that's something to take serious. And a parent may hear that one phrase and they're like, wait a minute, I heard that. This was sent home. Yeah. This was an email that was sent. This was something that was put in a backpack, or something to that effect. There might, people learn differently. There may be videos that we are embedding into these emails that we are sending, or QR codes that they can press, put their camera on, and it's a video that they can watch, something quick, because we know our attention spans are not, especially in uncomfortable situations. But as we continue to get the knowledge out, it's just like, it's very something similar to the idea that a lot more people are going to therapy now. Why? Because more people are talking about it.
Okay, thanks.
You're welcome.
Amy, I have a question for you. You talked about the acronym that you're seeing, especially in social media and on text messaging. And I know one of the things that's really concerning is that sometimes we see kind of replication, that when one person may complete suicide, that we may see others who have been thinking about it then go to the next level of intensity or extremeness. Can you talk about, if we see KMS, how is it that we can respond then if we're not a clinical provider?
Yeah. Breathe first. You as the individual, that's the space of managing your own feelings and kind of processing what you think about the ideation or the idea that, whether it's your child, another loved one, a family member, or a friend, making those types of text messages or anything like that. The biggest thing is to breathe so that you can regulate your emotions, because we don't If we move out of our emotions, we tend to make missteps, say the wrong thing, say inappropriate things. We don't want to say things like, you don't want to kill yourself, or you don't want to harm yourself, like, because that makes it seem trivial, when to that individual, this is a very serious thing for them. Whether it's a fleeting thought, when we're talking about frequency or duration or intensity, for them in that moment, it's their thought and it's their feeling. So we want to manage our feelings. We want to come to them and ask the question, hey, you got anything how was school? Sometimes it's, or, what's going on around. Again, it's the spaces of listening to them, observing their surroundings, understanding the context of, and the context of what's surrounding them, right? We may have some person that says, oh, and this may be from a religious standpoint, when I'm ready to go, I'm ready to die, because I know that I will live. And depending on whatever your religious affiliation is, that may not mean that they want to commit suicide. That just may be a religious statement or colloquialism that they've heard in the process. So we want to understand the content and the context of what is being said. But we sit down and we begin to ask questions. I like to say to my clients and to my other young people that I love, I'm here for this. This is what I'm here for. So let's talk. We began to observe them. We began to be around what they're doing, so that you can understand a little bit better the why. Did that help?
Thank you so much.
Mm-hmm.
Hi there, I have a question. Amy?
Yes, I'm here.
Okay. What percentage of self-deaths, people that commit suicide, and I heard that is an outdated term now, but what percentage have shared with their parent or their CASA or that they want to commit suicide? I mean, I don't understand what we look for with our people, because, I just can't see somebody coming up to me and saying, I'm thinking about taking my life.
So here's the thing. Now, I don't know the percentage. Kristin may actually have that percentage, but there is documentation that I've read that, especially with young people, they usually say something. There's something that they're going to say within, maybe about 2 or 3 weeks before, and it might look and sound like, I want to die. I just don't care anymore. People will be better off without me. I'm such a burden to my family and to my friends. I don't have friends. We're also looking at, those are things that people say from a negative, but you can also have children that are extremely high achieving. Children that put a lot of pressure on themselves to achieve, whether from a scholastical, from a scholastical standpoint or from an athletic standpoint, or so much pressure, or they're the super helpers. You have to pay attention, and you stop and you ask questions. Young people especially, they tend to kind of tell you, my young people that are coming in this door, it's those spaces of, I feel like I'm a burden. I just don't want to be here anymore. Life is so hard. It just seems like life would be better without me. Those are trigger statements. Those are statements that your antennas should be going off, right? For the child that does not say anything, those of us that have worked in the school systems, you're watching a child that has been vibrant and outgoing, helpful and all of that. And then all of a sudden they're closed off, hoodies over if the schools allow them to wear the hoodies, or if you're watching children and it's summertime and they have sweatshirts on. But understand, I have a teenager, they wear sweatshirts and stuff in the summertime. It's something that I don't understand. I don't think I will ever understand it. But if they were short sleeve kids and all of a sudden they're wearing sweatshirts and they're covering up, those are signs that we need to check in. We need to sit down and
Amy, so how do you go from viewing any of those to saying, hey, are you thinking about killing yourself? I mean, I don't understand how you gently go there to have them talk to you. Help us understand the verbiage here.
Okay, so that verbiage looks like sometimes we're not going to come and talk to them gently. So I want to make sure that I say that, especially if you've been listening and you've been observing, sometimes we need to be very direct, okay? If you are managing a child or an individual that is a little bit more sensitive, it is the conversation of, hey, can you come and talk? Let's sit down and talk. You know, I've been kind of watching and observing some things going on with you, and start giving them those statements back that you've heard. You know, is it something that we need to talk about a little bit further? Well, and I'm doing a little role play here. Well, no, I don't really have anything to talk about. It is, then that looks like, well, I've heard you, say this, and I just want you to know that I'm here for you. Because sometimes you have to build this space of trust. A lot of times, if you have individuals that want to harm themselves, they may not say anything because they may already be at that point. And if there are, as a clinician and as a mom personally, that is a difficult space, but it is gently having conversation with them, building spaces of trust that you might take a little extra care with them and seeing, talk to me about what you need. Know that I'm always here for you. I'm here if you need to talk, because if it gets that bad, you'll be the one that they'll come to. Did that help a little bit? Did I give a little bit more of the terminology or some of the approaches that can happen?
Yeah, I hope you're right. I hope it is a faith build, not faith building. I don't even know why I said faith. I hope it is trust building, and that person will come to you. I mean, you see so much with social media that you miss the cue, So, but thank you, Amy.
Yes, and then also, this is one thing in different trainings that I've done concerning suicidal ideation, and in my experience personally and as a clinician, sometimes individuals are wired. It's just the first thing that's going to come to their minds. It's a part of the way that they process information. And to others, that ideation is not a part of your paradigm. It sounds like, well, why would you think about that first? But sometimes people are wired to do that. And in years past, as mental health professionals, as helpers, as healers, we have been conditioned to, one, fear the conversation, and so we don't really say anything, or we tiptoe and dance around it, or number two, we think that we're the ones that are supposed to save the day, when the idea of choice is still, individual choice is still the main thing that is there. If you have an individual where this is just a part of their process, we're working hard as clinicians, as healers, as parents, as teachers, as lay people, other lay people in the field, business people that are out here to provide these coping skills. That's why you have safety plans that become so important, where you are asking them, well, what are some things that you do when you feel great? What are some things that happen when you're not feeling so good? So that you know, if they're coming in, you're like, okay, I observed this, I observed that. Talk to me about your coping skills. We're presenting those coping skills to them that they come up with, or that we come up with together. So that's also a part of building that rapport, building that trust with them, is understanding what they like to do to help them feel better.
Amy, thank you so very much. If you have more questions specifically for Amy, you can feel free to message Amy directly or put them in the chat box, and we will be so happy to make sure that those questions get answered. We want to make sure that we have time for Dr. Feeback as well. And so I'm going to now turn it over to Dr. Feeback to do a little bit of an introduction, and then we'll put up her presentation.
Sure. Well, good morning, everybody. I just want to thank you for having me. As Sean said, my name is Kristin Feeback. I am the CEO and the president of CommCare. I'm going to do a presentation, but actually, you know how kind of when you start a presentation, you kind of fill out the audience, and I hear some of your questions. And I looked in the chat box and I kind of saw where some of the organizations that you're from. And so I definitely have some stuff I'd like to add from what Amy said as well. So I'm going to share that with you. But just a little bit of my background. I'm a clinician as well. I did private practice for a while. I've worked at a state hospital in Kansas for a while. So worked directly with patients that have psychiatric issues. And then, I'm really passionate about informing people, educating people. I really resonated with, I think, your question, Mona, when you're talking about the parents and the education piece of it. That is kind of, to me, where the stigma comes in, is, you know, that perception. I mean, I think all of us, you know, as parents, we want our children, we believe, you know, that we want them to be good. We want them to do well and stuff. But I think sometimes there's a stigma that some people have where my kid would never. And I think it's our due diligence to do a lot of education. So I'm going to go ahead and go through this slide. I did do it for Baker University. I had the education department come to me and ask me to do a presentation to future educators. So that's kind of the context of what some of the slides I'm going to be going over. And I am from Kansas originally. I'm actually, CommCare is a non-for-profit located in Missouri right now. Anyway, so I'll go ahead and share this with you. Go ahead, Sean, if you want to move it. So one of the things that when you talk about death by suicide, there's all different kinds of language to use around the topic of suicide. So and some of you already know this and some of you may not. So I'm just going to do a little bit of education. So death by suicide is caused by injury to oneself with the intent to die. And then there's a suicide attempt, an attempt to die by suicide that results in survival. It may be referred to as a failed or unsuccessful suicide attempt. And we really, in the mental health profession, we try to stay away from that kind of language, because it means that it implies a suicide that results in death is successful and a positive outcome. And that's not the direction we want to go with that. Thoughts of suicidal ideation results from feeling you can't, oh, hang on, the screen's in the way. Feeling like you can't cope when you're faced with what seems to be overwhelming in life. And I guess one of the things I want to say, and I was trying to look it up when Amy was talking, there is a statistic somewhere, and it's about 40% of people that die by suicide, they don't necessarily have a mental health diagnosis. So sometimes, you know, people are in situations where And it's not just teens, people in general, they get into a situation where they just feel like, I can't move forward, I can't move on. And so anyway, I just felt like that statistic was alarming. And that's something we all need to be aware of, whether we're a mental health professional or not. Okay, go ahead. You can move the slide. There you go. So this is just some statistics that kind of coincide with a little bit what Amy said. I mean, 700 people die by suicide every year. For every suicide, there are many people who attempt it. And generally a prior suicide attempt can be one of the single most factors that mean that people could potentially attempt or succeed and die or have a death by suicide. Suicide is the 4th leading cause of death among 15 to 19-year-olds, and 77% of the global suicides occur in low and middle income countries. And then I just went ahead and added here, and this is from the WHO organization, of the most common methods. Go ahead. So I went ahead and I included some data here, just things that I looked up. So there's a study that I found to be very alarming, and that's why I want to share it. So in 134 children between the ages of 5 and 11 who died by suicide between 2013 and 2017. So 95% of suicides actually occur within a family home, and 65.6% are in the child's bedroom. The most common way children die by suicide is by hanging, particularly, like I said, in this study here. 18.7% of children die by suicide using a firearm. And you can continue to read this. Sean, is there a way this is going to be posted somewhere where people can actually refer to these and go into more detail?
Absolutely. We'll make sure that all participants receive these.
Okay. Mental health concerns were identified in about a third, so 31.4%, 27.1% reported trauma. And then I went ahead and broke that out into exactly the kind of trauma, how many frequencies, multiple trauma events. 39.8% had family-related problems. 32% of children had school problems. 11.9% had a history of suicidal behavior. 24.3% had a history of suicide thoughts. And this last is why I underlined it. Most children who die by suicide had made a suicide statement in the past. So I think that addresses one of the questions that somebody had. So that was in 79.6 of these 134 children that died by suicide. Okay, next slide. So young children who attempt suicide are 6 times more likely than their peers to attempt suicide again in their adolescence. To prevent child death and subsequent suicide attempts during the teen years, it is important to intervene as soon as possible. So these findings that I just shared with you promote more robust mental health and suicide risk screening in primary care settings, paired with lethal means safety counseling on safety of firearm storage and family-based interventions could help reduce suicide risk in this age group. So one of the things that I'm finding alarming, just to kind of go into this, is my husband's a coach and a teacher, and so he's been in the field for 25 years. I had 25 football players at my house the other night, and I just was asking them, because like what Amy said about listening, kind of what kind of interventions do we talk about it at the schools? I know at that school they have Zero Reasons Why, which is a student-led organization I'm going to talk about later. But I guess what I'm trying to say is, I think, Amy, I just want to support in what you said 100% about talking about it. And definitely, I think student-led things are very important, because a lot of times our student and adolescents listen to their peers. So anyway, go ahead. So what we also found is there's a link between suicide and mental health disorders, in particular depression and alcohol use disorders. Many suicides happen impulsively in moments of crisis, as I was saying earlier, with a breakdown in the ability to deal with life stresses. And those are some of the stresses there: financial, relationships, different things like that. Experiencing conflict, disaster, violence, abuse can create a sense of isolation. Suicide rates are also high among vulnerable populations, and I went ahead and listed what some of those are. But by far the strongest risk of suicide is a previous suicide attempt. So important considerations, students may have trouble expressing their intent. A lot of what Amy was saying, students may not know how to say their feelings and don't want to burden someone. So again, just supporting what she said, any sign of suicide or concerning change in a person's behavior should be taken serious. Generally, children and teens don't really want to die, rather they want to escape their psychological and or physical pain and feel there are no other options. Next slide, please. So here are some things that I went ahead and really tried to get down to what we see a lot. So these are some situations or events that can occur when we think about being preventative. So if any of the teens or adolescents, children have some of these events occur, these are the things that we need to really think about and have conversations and listen. Next slide, please. So being proactive about crisis situations, asking them, keep them safe, listen to them, encourage them, and then follow-up's really important. And I got that from the National Institution of Mental Health. Okay, next. So one of the things, and again, I said I was from Kansas, that I think is important is I see a lot of people from Missouri, and I know that I've been in panels before, whether it's school counselors or teachers themselves, where there are some student-led type organizations within schools. I think it's really important for all of us, no matter if we're a parent or if we're a teacher or we're a mental health professional or something within our communities, to find out what those resources are and support them. Because, I have a lot of respect for students that step up and want to get involved in student-led things, but for some that's hard to do. And I think just having some extra backing and some support that they need to be outspoken about an issue that maybe that's very difficult to talk about, but it may be coming completely out of their comfort zone to do that. So particularly from Kansas, we, like I said, have the 0 Reasons Why. I don't know how many of you are familiar with that, but if you look it up of the intent and how it works, it's a great program. It's actually at a lot of high schools within the area of where I live, and it has been successful. It's getting people talking. SOS, signs of suicide. This is reaching into our adolescents and our young children, 11 to 13. Okay, next slide. Some of the other things, and this is the other thing that I found, and again, in support of Amy, is just the resources that are out there to educate people that are directly working with children. So when I think of schools, I think about educators, administrators, and all that. So in Kansas, we recently, there was a news story on Blue Valley High School and how they had mental health first aid training for their teachers. And so again, that's not specific to just suicide, it's specific to mental health in general, and signs and different things. But to me, when the news thing came on, it's great, but I'm thinking, wow, this is 2022. Like that should have been done that should have been done a long time ago. And so I'm actually really working hard with some people here at CommCare to getting into more schools and really making the school administrators, superintendents, student resource officers aware of what resources are out there to do this education with people that are working directly with children. Because I think if we equip people and teach them how to ask the questions, much like what some of the participants had kind of been saying, if we equip them, then when a situation occurs, we've been preventative, we've been proactive, and we can engage in conversations and link people with resources. The one thing I want to show you on this on the last box here on the 988. So just to give you a quick overview of that. So CommCare is one of the 7 call centers in Missouri. So if you dial 988 and you have an 816 area code or a 660 area code, We facilitate the calls in 22 counties. And so what was really intriguing to me is I went to my daughter's volleyball game this last weekend, and I went into the restroom. I know, TMI, but I saw pictures in there of where kids had drawn pictures and they had just call 988 or text it. And I can't tell you, that made my whole weekend, because that was in the stall of a junior high bathroom. And so, just things like that are telling me, like, we're getting it out. I know that the statewide in Missouri, they're going to start getting more marketing and more material out on it. But just from a perspective of being a call center and taking the calls, we are seeing a very big increase in our call volume. We are on the calls longer than we ever have been since the interception of 988, July 16th. And so it's a huge resource. And again, it's not just, I want to specify, it's not just for suicidal ideation. It is a crisis hotline as well. So if I'm a mother and my child is really concerning me or having some type of a crisis, I can call that number and I could get linked with some resources. Okay, so 988 has been a long time coming, and I'm glad it's here. There's a lot of things that are still being worked out with it, geolocation, different things like that. But anyway, it's going to be such a valuable resource. Okay, go ahead and do the next slide, Sean. So anyway, for those of you that are in schools and stuff, I just did some capturing here of things that you may want to consider in a school district, what their policies and procedures are surrounding crisis and suicidal ideation, how that's currently handled. I highly recommend that educators are really imperative that they get educated in preventative, use prevention programs, different things like that, on what to do when a situation arises between a crisis with a student and all that. And then there's all these other kind of resources, the practice of the social emotional learning environments and different things like that. I mean, I could sit here and talk to you for hours, but I think there's just so much out there right now that to really know, making an impact in your community and where you're at, know what resources are available. And if there's a lack of them, I think it's important that we know what those are. So I'm looking at the chat line and just kind of having a lot of questions about 988. So really quick, can you get the other slide thing up really quick, Sean? I know I'm trying to keep track of time here. Okay, if you could go ahead and do 2 slides over, that would be great. So just to let you know, 988, so it is nationwide. Okay, so we knew 988 was coming a couple years ago. And as a call center, we were the crisis hotline. But when as time moved on and we knew that there was more funding coming for this, we went ahead and staffed up. So we've increased our staffing to be able to handle the increase in volume with our calls. But 988, there's still the 1-800 crisis number that's available. People can still call that, but 988 is the simple 3-digit number that people can call. And it connects people to a caller. So people are not going to get a message. Somebody's directly going to answer the phone. And depending on what is going on between the caller and the crisis specialist, that's where we figure out what the next step is. So go ahead and do the next slide, please. So why the need for 988? Well, too many people are experiencing suicidal crisis or mental health related distress. The pandemic was, we all went through it, and in our various capacities, we're influenced by it. And so this really brought to light a lot of mental health issues that are occurring. And so anyway, I went ahead and included some statistics there really quick about suicide and death by suicide. Okay, next slide, please. So funding from 988, it came from our president. He went ahead and wanted to fund crisis services in general. So facilitated more funding to the call centers, but also began facilitating money towards mobile crisis response. So, and I'll explain that here in a few minutes. Next slide, please. Just to let you know kind of how our crisis center works, we have a director of crisis services. We have a senior call center manager. We employ 7 full-time staff, 23 part-time staff. One thing with 988 is when somebody calls, we have to, within 72 hours, do a follow-up call to them just to make sure that they were linked with services, because that is an issue right now. I mean, people getting in the gaps. And so, so that follow-up calls to make sure that they were linked to what they were referred to. And right now, so Missouri, there's, for some of you that are in the mental health field, well, in a lot of fields in general, there is a workforce issue. And so anyway, Missouri went ahead and changed their qualifications for call specialists. Now you can be a bachelor's level person with 3 years of behavioral health experience. Our call center is completely remote. So people are in their homes answering these calls. We provide the equipment for them. And then we have 3 shifts, day, evening, and overnight. So Sean, I don't know, is there a question and answer time? I don't want to take up if this will be displayed somewhere. I mean, I just don't want to take up any more of Amy's time or your time because I've got more slides.
So we have about 8 minutes left. And so I think if we share out the resources, would it be okay to have participants ask questions of you?
Sure.
Thank you. So are there any questions for Dr. Feeback about 988 resources or some of those proactive measures we can really utilize?
I have a question.
Please.
Okay, about that SOS program, I saw in one of the slides that it said there's an increase in the ages 5 to 11. So it kind of boggles my mind about a 5-year-old, unless it's like they get a hold of a handgun, which has happened in the St. Louis news. Do you think they'll be instituting, and I know it's a tricky age, but having worked with kids that 9 to 11, that they'll be instituting the SOS program in younger grades? Because if it's increasing, that at least for parents to learn how to talk to younger children, because they certainly would think, oh, not my 5 or 6 or 7 or 8-year-old.
I would hope so. I think early prevention's the best. And so in terms of if they're going to be instituting it, I haven't heard one way or the other, but I do know that I think schools are more attentive to and being educated by mental health, community mental health centers within their communities about the age as it's getting younger and younger, and doing more prevention. And so I think it's getting there, but I do think things need to start early. We automatically think the teenagers and stuff.
Do you find that sometimes that parents, when their children are, well, certainly 5, like 6, 7, 8, or 9, they're just thinking, there's no way my child would have any ideations of suicide, and that it's harder to reach parents about that?
I do.
Okay.
I do.
I have a question as well. What are your thoughts on, I thought the statistic was really alarming, but also made a lot of sense about, I think it was 67% of child suicides are happening in their bedrooms. I'm a CASA here in St. Louis, and, we don't really instruct on how parents should parent their children, but we do have parents ask questions, right? So, it's that fine balance of helicopter parenting, but also knowing, like, a statistic like that, thinking of the young people in my life, it's like you never want them to close their door.
Right.
What have you seen around that? Like, what would you think? Do you have similar feelings? It sounds like you're a mother as well. So
right.
Curious what your thoughts are.
Well, again, in support of what Amy said, I just, you know, I think just having the conversations, I think asking questions to your kids, even as young as 5, and just, you know, try to get an idea. You know, schools are doing some things. Okay. So some schools are being more proactive than others. I think if schools are communicating well with parents of what they're, you know, if there's been an assembly or if there's been a counselor come in the classroom or whatever, that could be the beginning or a foundation of a good conversation between a parent and a child, right? Um, and Amy, maybe you can chime in here too, but I do think that I think we need to start having more conversations even at a younger age. That's for sure. I don't know if that answers your question, but yeah, I mean, I believe in talking about, I believe in asking your kid questions just to kind of gear where they're at and what they've heard. And then talk about at a young age coping skills. I think that's important. So when they get into situations prior to a situation occurring, it's already kind of been a foundation and been taught about support systems and how you can talk about anything and how it's a safe environment to come to and talk to. I also think additionally, and I haven't done a lot of work with children, but I think it's good to establish, have kids establish relationships outside of the parent-child relationship, to where if they don't feel comfortable coming to you with something, they at least have that additional adult or somebody that they can talk to. And then if there's a situation arises, then, you know, appropriate action can be taken. Did that answer your question?
I have a little something also to add to that.
Yeah.
So here's the space in working with parents, and we're talking about safety plans and how to keep the home safe. We talk a lot about firearms and different things like that, but sometimes it's everything. And I think that along with, if you have to create those spaces of safety where you are removing lethal or potentially lethal weapons that can be used as weapons for harm, I think you have to have these conversations. You are talking to them. You're not just removing them. It needs to be very clear that this is the why. It is the space of understanding that we are taking it serious, that there's a potential, you know, that there's a harm that is coming here. Like what was stated earlier, you have sometimes it's pain, sometimes it's one question that I usually have to ask: is it attention? Is it for attention seeking, or is it to escape pain, which was one of the statistics, or escape the space of living? And the communication is so key. But to my parents and to my teachers and those that are on this call, you have to work at regulating yourself and understanding how you feel about it, and understanding if you do have a bias, you have to check your bias, because they will pick it up. They will pick it up and they will shut down. They will not talk to you. So the biggest thing for us as big people when we're talking to little people is understanding where we sit in this process. And if we haven't regulated ourselves, then we need to maybe have someone else, someone outside of the parental space, like what was mentioned before, what Kristin mentioned before, so that, and we need to get better knowledge on what is the terminology that we need to say and to express to them to help. But it could get that bad where you have to, you know, start moving things out of the house and locking things up. And I'm talking all the way down to butter knives. And everybody in the house has to understand that this is what we are doing to work at, doing our part to work at safety. a grim, or it sounds like it's a grim space, but I've worked with people where that has had to happen, and they've been able to titrate down from, we can put the knives back in the drawer, we can have the razors back in the under the cabinet or in the closet, or different things like that. We just have to attack it head on, and we can't present scared, even though we may be shaking in our boots on the inside.
Thank you so much. And I just want to take a moment to honor everyone's time, that it is 10:01 right now. I'm going to ask for Amy and Kristin to stay on for just a few more minutes in case there are any last minute questions that we have coming in right now. But for those of you who joined us today for this vital conversation, thank you all so very much. We will be sending out slides as well as some follow-up resources after this session, and this session should be available online, hopefully within a week or two. But thank you so much for taking time out of your very busy schedules to have this incredibly important conversation, and recognizing that it's not just a one-time conversation, but an ongoing conversation that we have to have with children, adolescents, and with adults as well. So thank you so much for joining us, and our wonderful, wonderful speakers will stay on for just a moment or two longer. Thank you all so very much, and thank you to our speakers.